So, peri-prosthetic distal femur fractures, the incidence is greatly increasing nowadays because of lot of arthroplasties as well as osteoporosis with the use of robotic pins which we get in the distal femur areas. So coming to the classification, this is a basic classification which was applied to the peri-prosthetic distal femur fractures. It just gives a routine idea of and from an undisplaced to a loose prosthesis, A1, 2, 3. Does not hold much significance and does not give any prognostic indicator and the way of managing a fracture. Then comes the SU classification. It is also based on the same Levy's classification, but it does not include the undisplaced ones because it is very rare to get an undisplaced peri-prosthetic distal femur fracture in which already when the limb is under so much of tension, when the alignment has been corrected, the soft tissues are not as they were earlier. Therefore, they usually displace within a very short period of time usually and do not remain undisplaced. Then the second fracture, the first type A1 fracture is always distal to the stem. Type 2 starts at the anterior flange and goes proximally. Type 3 goes below the prosthetic border. And type 4 are obviously fractures with loose prosthesis. Again, a new classification based on SU classification, but they have again divided these types into various types of replacements which we do. Type A are the surface replacements, usually the CR knees. Type 2 are posterior stabilized, type B is posterior stabilized knee. Type C are constrained or hinge prosthesis, and type D are the distal femoral replacements. And these types are further divided into type 1, 2, 3, 4 on where is the location of the fracture. Type 1s are always in the shaft proximal to them. Type 2 are again same from the proximal aspect, from the distal aspect of the prosthesis going proximally. And type 3 are below the prosthesis, and type 4 are obviously with a loose prosthesis. And depending on all these types, they have devised a classification system on management of these fractures, how to manage them. So all the proximal fractures, they need to be fixed as they consider the prosthesis is stable and the fixation needs an internal fixation by any method. Type 3 and 4 fractures are usually, type 3 is distal or distal to the flange of the fracture, and type 4 are with a loose prosthesis. Depending on the bone stock available and the fracture pattern, mostly they would require a revision replacement, and type 4 obviously requires a tumor prosthesis with replacing whole of the distal femur. So this is a basic general overview of what the distal femoral fractures present and in the way they need to be fixed. So when we come to the fracture fixation, the aim of our fracture fixation is to create a stable fixation which allows immediate mobilization and early weight bearing. For that, we need to create a loadable construct. The construct should be loadable under appropriate load by maintaining an appropriate axial alignment, length and rotation of that fracture in a rigid way but biological to allow early rehabilitation. The choice of fracture fixation options depends upon the displacement of the fracture, the location of the fracture, the bone stock available for us to fix, and the available inventory which we have. Usually while fixing these fractures, there are two issues for us when we fix them. One is the distal bone stock available for us to get sufficient amount of hold of whatever we are doing there, and is the prosthesis really stable? On a broader overview, again the same type 1 fractures are amenable for intramedullary nailing made by an antegrade or a retrograde nail. Type 2 usually needs a nail plus plate or a dual plate construct, and type 3 again a dual plate or a revision of a femoral component. So bone loss and the fracture pattern and the prosthesis stability dictates the way we manage these fractures. So again the same kind of algorithm which we follow, and it is followed everywhere depending on the stability and the available bone stock there. But the detailed plan while we fix this fracture depends on the fracture orientation and the location, the extent of the fracture, the level of comminution, patient's bone quality and residual bone stock should be taken into account, and the implant which is available is also an important factor while we choose the fixation options. Definitely an open box or a closed box we need to know beforehand so that we choose the implant appropriately. And definitely the approach. As for a fixation or revision of a proximal femur or a hip hip peri-prosthetic fracture we access through the same hip approach. Therefore, we are able to expose the hip from the same approach. But considering a knee, sometimes it's not, many a times it's not always possible to just expose the knee. So it's better to expose the knee when we are dealing with type 3 fractures where the fracture goes distal to the flange of the fracture, because we need to access a very distal area which is not possible with a medial or lateral approaches, and at the same time we can look for the stability of the fracture through the same TKR approach. But if the fracture is proximal to the anterior flange and we know that the prosthesis is stable, we do not need to go through the arthrotomy approach, and we can very well manage it from either way. That is the difference between peri-prosthetic fractures of the hip and the knee. So the inventory, these are the distal femoral plates. In majority of the cases, they are workhorse for fixation of these fractures. Then we have this NCB, non-contact bridging plates, which are not available to us, which gives multiple options of fixation. We have distal femoral nails, which have multiple locking with compression bolts and multi-lock available. These are the recent ones from the Synthes ones. I don't think they are available for us right now, because usually when we are fixing these fractures with a distal femur nail, the entry point of the distal femur nail through the box is usually more posterior than what we have for a routine distal femoral nail. Therefore, passage of a normal or a standard distal femoral nail will actually displace the fracture. It is not going to keep the fracture reduced there. Therefore, if we try to put a normal distal femur nail through a prosthesis, then it's not a good idea. Therefore, we need such kind of nails which are high bend. So the degree of the femoral bowing is more in this. Even the bowing is more as well as the distal bend is more, so that we can pass it through more posterior entry through the notch and get a good alignment. Maybe over the period of time we may come up with these nails we will get available in India. So here we can see a standard nail causing deformity at the fracture site. And again, these are nails from the Synthes which have a washer which acts as a lateral plate, interlocking screws, which avoids the need to use a distal femoral plate as well for these fractures. So there are some critical questions before we go for execution that depends on prosthetic stability, the fracture location and its personality, the mode of healing which we expect for a fracture, bone stock available, inventory available, the access and approach by which you are going to fix this fracture, and most importantly, it's the host factors. Is the host good so that it will throw bone very early so that the fracture heals? We need to augment these fractures with some biological methods like teriparatide and bisphosphonate, so they keep their bone stock good over the period of time. So this is a case 1. It is a 65-year-old male with the TKR done 4 years ago, a stable prosthesis, landed up with a trivial trauma. So the mode of trauma also gives us an indication of what type of fracture we get. Just a trivial twisting injury, we get a short oblique to a spiral fracture, and usually it is proximal to the prosthesis there, and the prosthesis remains stable. The patient was the patient's recovery was uneventful post-surgery. So this is an immediate post-operative X-ray of the same patient. As this is a simple fracture pattern and a good bone stock, it was managed with open reduction through a lateral approach, lag screw fixation of the fracture, getting an anatomical reduction, and a lateral lock plate. Usually, when we have these fractures with osteoporosis, the bone stock is not that good. Therefore, even if we feel we are putting lag screws, they are not an actual lag screw, they just remain as position screws and do not provide that stability. In that case, if you feel such, we need to add a separate plate or put an intramedullary nail in addition to this lateral plate. But as here, the fracture was, the bone stock was good, and we could get a good anatomical reduction, it was fixed. And as I said, we need a loadable construct. Therefore, we need the medial portion of the bone should be loadable, so that the prosthesis, the construct remains load sharing and the fracture heals up eventually. This is a 3-month and the 6 months post-operative X-ray, and at 1 year we can see the fracture heals by primary intention without formation of callus, definitely because of lags and a good bone stock. So again, a 76-year-old female, TKR a year ago, some bending and twisting injury leading to this comminuted fracture proximal to the prosthesis, treated with a MIPO plating as the fracture was comminuted. So again, there are multiple options of managing this case. We can do this case with a nail, with a plate, or use 2 plates, or use a single plate. But as we could get a medial stability or a medial continuity as the comminution was central or lateral and it was done in a minimally invasive fashion, maintaining the biology, I didn't feel a need to put a medial plate or add an extra fixation. And this is over the period of time at 6 weeks, and the callus is seen. 9-month post-operative and a year the fracture heals with callus. So the principles also depend on our trauma principles, the length of the plate, the number of screws, the spanning of the plate to create an appropriate bridging construct which will be loadable but as well as stiff but not very unstable that it does not throw callus. So there are many intricacies in fixation of this fracture. A case 3 again, a simple trivial trauma 5 years ago, TCAR was done in 2008 years ago. We can see again a spiral fracture but a fracture extending proximally. This is on table views. So the shaft fracture was fixed with lag which was undisplaced and the remaining fracture was fixed. But even after fixing it, reducing it anatomically, we could not get a very good anatomical reduction because of osteoporosis. Lag screws were placed and an anatomical lateral plate was applied. Again, we need to keep in mind that a lateral plate is one plate for all. Therefore, one plate does not fit every patient. As the patient's anatomy is different, you need to calculate. We cannot keep this plate, as we try to flush this plate to the bone, it may displace the fracture. Therefore, it should be applied in an internal fixator way. So, a lateral plate was applied, but I was not very happy with the interfracs. Therefore, a medial plate was applied from a medial approach. And this construct with a medial and a lateral, therefore no arthrotomy was done. And this is an immediate post-operative X-ray of the same patient getting the alignment, and it healed up eventually. Again, the last case done on 5th of Jan, 10 days ago. The patient landed up while after physio, she turned in bed and heard a crackling sound, getting a distal femoral shaft fracture, a transverse short oblique fracture. It was managed yesterday. We fixed this fracture with an antegrade intramedullary nail and a 3.5 system with some screws. We could get an anatomical reduction to load the fracture, load the construct and the fixation here. So the take home message is that these are the points we need to take care, the stability and the bone stock, and manage it on the principles of a biological fixation to create a loadable construct. Thank you.
Thank you, Vijay.
Thank you.